Assalamu alaikum. Today we will talk about the anterior abdominal wall, part 2. Now, this lecture will start by describing the following. We will describe the inguinal ligament and inguinal canal in the male and female and the differences between the two. Secondly, we will explain the contents of the canal and how inguinal hernias develops. Of course, that will be an anatomical and surgical presentation of such hernia. And then we will describe the relationship between the femoral canal and the inguinal canal, or the inguinal ligament, and the anatomy of the femoral hernia. This is a view showing the internal surface of the anterolateral abdominal wall. It's covered with parietal peritoneum. So all what you see here is a parietal peritoneum. Now the infra-umbilical part of this surface of the wall exhibit several peritoneal folds. So those are what we call the folds. Now some of which contain remnant of the vessels that carry blood to and from the fetus. There are 5 umbilical folds, 2 on each side and 1 in the median plane that pass toward the umbilicus. Here is the umbilicus. The median umbilical fold, so this is the median umbilical fold, extending from the apex of the urinary bladder to the umbilicus. It's covered the median umbilical ligament, the remnant of the urachus that joined the apex of the fetal bladder to the umbilicus. Now we don't need it, so it's just a fold of ligament. There is another one called the medial umbilical folds. They are lateral to the median umbilical fold and covers the medial umbilical ligament. This is the remnant of the fetal umbilical arteries. There is another fold called the lateral umbilical fold. Now, lateral to the medial covers the inferior epigastric vessels, which are functional ones that bleeds if you cut it. And this is one of the major blood supply of the anterior abdominal wall. So we have the median, the medial, and the lateral umbilical folds. Now there is a depression lateral to the umbilical folds are peritoneal fossa. Now those peritoneal fossa, each of which is a potential site for a hernia. So this is a weak part in the abdominal wall from inside. The location of the hernia is one of these fossa determine how the hernia is classified. So there is a shallow fossa between the umbilical folds are. There are supravesical fossa. It is between the median and the medial. Okay, so this is small part here between the median and the medial, formed as the peritoneum reflects from the anterior abdominal wall into the bladder. The level of the supravesical fossa rise and falls with filling and emptying the bladder. So this is a kind of a space for the bladder to extend. There is a medial inguinal fossa. Medial inguinal fossa. It is between the medial and the lateral umbilical fold. So this space here, or this one. It's called, or usually it's called Hasselbeck Triangle or the Inguinal Triangle. These are potential sites for direct inguinal hernia. There is another space called the lateral inguinal fossa. It is lateral to the lateral umbilical fold. So this is the lateral to the lateral umbilical fold and includes the deep inguinal ring and our potential site for the most common type of hernia in the lower abdominal wall is called indirect inguinal hernia. So this is the site of the indirect inguinal hernia. Okay, thank you. Now here what you can see is the inguinal ligament. And the inguinal ligament is actually the double folding of the aponeurosis of the external oblique muscle, which is one of the flat muscles of the anterior abdominal wall. Now, the inguinal ligament have attachments. The attachment of it is laterally from the anterior superior iliac spine and medially to the pubic tubercle, and extending from this point to this point, it will give you the inguinal ligament that will be a site for origin of some of the muscles and some other muscles to be inserted in. You can recognize here two muscles passing just behind the inguinal ligament. The first one is the psoas major tendon, and the other one is the iliacus. So this is the iliacus tendon as well. So it's passing just behind. Now we will describe the inguinal canal. Now, what is inguinal canal? Inguinal canal in adult is an oblique inferomedial directed passage between the superficial and the deep inguinal ring. So it's extending from inside the abdomen to the outside. So it is a passageway. Now, this will run through the inferior part of the anterior abdominal wall. The inguinal canal lies parallel and just superior to the medial half of the inguinal ligament. So just here and inside. The main occupant of the inguinal canal, or the main content, is the spermatic cord in males and the round ligament of the uterus in females. The inguinal canal also contains blood, lymphatic vessels, and ilioinguinal nerve in both male and female. Now, the inguinal canal has an opening at each end. We will describe it in a while. But as well as it contains roof and floor. Now, the roof is formed by arching fibers, those arching fibers, of the internal oblique and transversus abdominal muscles. So those arching fibers will form the roof. The floor is formed by the superior surface of the inguinal ligament. This is the inguinal ligament. And in curving of the thickened inferior part of the external oblique aponeurosis, the inguinal ligament thus forms a shallow through to this. The most medial part of the floor is formed by the part of the inguinal ligament that, rather than attaching directly to the pubic tubercle, and that, as the most of the ligaments does, they reflect to form the to be attached to the superior pubic ramus and called the lacunar ligament. So inguinal ligament and the reflecting part called the lacunar ligament, and that will form the floor. The anterior wall of the inguinal canal is formed by the external oblique muscle. So the external oblique aponeurosis, it will form the most of the, or almost of the anterior wall, with the anterior wall, the lateral part of the canal, being reinforced by fibers from the internal oblique. So external oblique predominantly and part of the internal oblique. Now the posterior wall is formed by the transversalis fascia. This is the transversalis fascia. It is a deep fascia, with the posterior wall of the medial part of the canal being reinforced, the medial part, by merging of the pubic attachment of the internal oblique muscle as well, and transversus abdominis, to form what we call the conjoint tendon. So conjoint tendon is a fusion of two muscle fibers, the internal oblique and the transversus abdominis. Now, on the inguinal canal has two openings on each end, as we mentioned earlier. The first one is called the superficial or the external inguinal ring, and that exit from the inguinal canal. So this is the exit to get outside or from the canal. It's a slit-like opening between the fibers of the aponeurosis of the external oblique. So this is what they call the diagonal fibers of the external oblique. Superior lateral to the pubic tubercle. That's the pubic tubercle, so it is above and lateral. The lateral and medial margin of the superior ring formed by the split in the aponeurosis are the lateral and the medial crura. They call the medial crura, lateral crura. The deep inguinal ring, we will mention it next. It will be formed by the entrance of the canal, and it is by outpouching of the transversalis fascia approximately 1.25 cm superior to the middle of the inguinal ligament. Now, how the inguinal canal developed is by the empouching of the fascia and the muscles to get out. Now, first of all, you should know something about this. It's called the gubernaculum outpouching. The gubernaculum is like a fibrous band, and that fibrous band will pull the testis. Now, the testis we started with was inside the abdomen, and then it will pull it through the abdominal wall, starting from the transversalis fascia, transversus abdominis muscle, internal oblique, and then the external oblique muscle. And this pulling and pushing will help to get the testis from inside to be outside, to be outpouched in what we call the scrotum. During this outpouching, the testis will take covers from all the layers that will be passing through. Now, that will give a remnant of the testis. It's called the peritoneal vagina, called the processus vaginalis. The processus vaginalis should be obliterated and closed alive. Sometimes it would remain as a patent duct, and that could cause the testis to get out and in the abdominal cavity. So it will be like a migrating testis. Sometimes it will have fluid inside that will create what we call is a kind of a hernia inside the abdominal wall. So to summarize the inguinal canal boundaries, we have this mold, like two muscles, two aponeuroses, two ligaments, and then fascias or tendons. The two muscles forming the roof, superior wall, are the internal oblique and transversus abdominis. The floor is formed by two ligaments, which is the inguinal ligament, and its medial reflection is called the lacunar ligament. The anterior wall is by two aponeuroses, external oblique aponeurosis reinforced by the internal oblique aponeurosis, while the posterior wall is by two T's, which is the transversalis fascia and the conjoint tendon, which is a kind of fascia. Now, conjoint tendon, to remind you, is the combining fibers of both the internal oblique muscle and the transversus abdominis. Now we will talk about another topic called the contents of the inguinal canal. Now the inguinal canal is, as we mentioned, it's a passageway for the spermatic cord. Now the main content of the spermatic cord is the ductus deferens. And that ductus deferens there are associated structure with it. That's coverings, okay, and that will blood supply, lymphatics, and everything. associated with the ductus deferens. There are two other structures, two other nerves that pass through the inguinal canal, like outside this ductus deferens structure. Now, the first one is the ilioinguinal nerve and the genital branch of the genitofemoral nerve. Ilioinguinal nerves was one of the nerves that's coming from the L1 anterior rami, and it is one of the major nerve supply of the anterior abdominal wall. The other contains is the spermatic cord in male, as we mentioned, and the round ligament of the uterus in the female. Now, talking about the spermatic cord. Now, the spermatic cord begins as the ductus deferens and associated with neurovascular structures passing through the deep inguinal ring lateral to the inferior epigastric vessels. So here coming like the ductus deferens. Now it will gain its coverings, as we mentioned, as it is passing through the inguinal canal and will be exit through the superficial inguinal ring. Now it will end in the scrotum at the posterior border of the testis and become surrounded by all the facial coverings derived from the fascia of the layer of the anterior lateral abdominal wall. So it will be passing from inside to outside, first of all through the transversalis fascia, which through the deep inguinal ring. This is a common site, again, for what you call the direct inguinal hernia. And then it will be passing between the roof and the floor of the inguinal canal till it will get exit through the superficial inguinal ring, which formed by the aponeurosis of the external oblique. Any failure in the descent of this will create a passageway and will create what we call a hernia. We have three supporting structures. Now the G is short for the genital branch of the genitofemoral nerve, and that will supply the chemasteric muscle. The S is for the sympathetic nerve fibers. They are surrounding the arteries, sympathetic and parasympathetic fibers on the ductus deferens. And the last one is the L, which is the lymphatics. That will drain all the testis and closely associated structure to the lumbar and pre-aortic lymph nodes. So, it is a chemasteric artery from the inferior epigastric artery, ductus deferens, which is the main structure here, or they call it sometimes the vas deferens. And then we have the T here, testicular artery, from aorta, P, pampiniform plexus. It's a venous network by maybe 12 venous channels, and that will take it to the this venous to the right or left testicular vein, and then the A is the artery to the ductus deferens from the inferior vesical artery. G is the genital branch of the genitofemoral. S is the sympathetic nerve fibers, of course sympathetic and parasympathetic, and L is the lymphatic vessels. Now we will talk about a short notes about the scrotum. Now the scrotum is a musculocutaneous sac containing of two layers. They are heavily pigmented, and they are closely related to what we call the dartos fascia. Now, if you remember dartos fascia, I will refer you to my first lecture about the anterior abdominal wall. It is like a layer of smooth muscle fibers, responsible for the rugae or wrinkles appearance on the scrotum. Now, because of the dartos muscle attaching to the skin, its contraction causes the scrotum to wrinkle and thus becomes smaller when it is cold, which helps to regulate the loss of heat through the skin. There are arteries of the scrotum, or the posterior scrotal artery. Now, with the posterior scrotal artery, is a terminal branch of the perennial branch of the internal pudendal artery. And there is the anterior scrotal artery. That is a terminal branch of the external pudendal branch, which is coming from the femoral artery. Now the veins will correspond to the arteries. So we have the same names of the veins, posterior scrotal and anterior scrotal. Lymphatic, it will drain to the superficial inguinal lymph nodes. Now there are like 4 nerves that supply scrotum, rich nerve supply. We have the genital branch of the genitofemoral. This is from L1, L2. We have the anterior scrotal nerves, which is drawn from the ilioinguinal nerve. So genitofemoral nerve, ilioinguinal nerve, bigenital branch, and anterior scrotal nerve. We have posterior scrotal, because we have anterior, so we have posterior scrotal, which is a branch of the perennial branch of the pudendal nerve, which is S2 to S4. That will supply the posterior surface. And we have the perennial branch of the posterior femoral cutaneous nerve. Posterior femoral cutaneous nerves coming from S2, S3. That will supply the lateral of the scrotum. Now the testes. This is ovular testes are suspended in the scrotum by the spermatic cord. Now the testes produce sperms, or the spermatozoa, and hormones called the testosterone. The sperms are formed in the what we call the seminiferous tubules, and those seminiferous tubules joined by the straight tubules to the retitestis. Now the surface of each testis is covered by the visceral layer of the tunica vaginalis. Tunica vaginalis is covering all the visceral layer except where the testis attached to the epididymis. So this part here is devoid of the tunica vaginalis. The visceral layer of the tunica vaginalis is a glistening transparent serous membrane and is closely applied to the testis, epididymis, and inferior part of the ductus deferens. Now we have the parietal layer of the tunica vaginalis is adjacent to the internal spermatic fascia, which is more extensive than the visceral layer and extends superiorly for a short distance into the distal part of the spermatic cord. Now sometimes there is a small amount of fluid in the cavity of the tunica vaginalis that separate the visceral and the parietal layer, allowing the testis to move freely within its side and scrotum. So there are fluid. Sometimes this fluid can increase, sometimes decrease, it depends. Now the testicular arteries arise from the abdominal aorta, just inferior to the renal artery. They are long, slender testicular arteries that pass retroperitoneal in the oblique direction, and they traverse the inguinal canal, becoming part of the spermatic cord. So it's one of the content of the spermatic cord. The testicular veins, they emerge from the testis and the epididymis to join the venous network, called the pampiniform plexus. This is the pampiniform plexus of veins, which goes maybe from 8 to 12 venous network. It's anterior to the ductus deferens and will surround the testicular artery and spermatic cord. They are a cooling system. They are thermoregulatory system of the testis, helping to keep this in a constant this gland into constant temperature. Usually it is 1 degree lower than that of the trunk. So if you are 36, the testis is 35. The left testicular vein originates as the veins of the pampiniform plexus. It empties into the left renal vein. Now the right testicular vein has the same origin but enters the inferior vena cava directly. So left testicular vein to the left renal and then to the aorta, and the right testicular vein is directly to the aorta. The lymphatic drainage of the testis is to lumbar and pre-aortic lymph nodes. There are sympathetic and parasympathetic supply through the testicular plexus of nerves which surround the testicular artery, and they are coming from the visceral efferent fibers from T7 segment of the spinal cord. Now the epididymis, short note about it, is formed by convolutions of the duct of the epididymis. The epididymis lies on the posterior surface of the testis, which is covered by the tunica vaginalis, except in its posterior part, where the epididymis lies. The ductus deferens begins at the tail of the epididymis. So this is the head, the tail, and from this you have the ductus deferens. As it is a thick-walled continuation of the ductus of the epididymis, the efferent ductidules transport newly formed sperms. The rete testis is a network of canals at the termination of the seminiferous tubules, as you can see here. Now the epididymis consists of head, body, and tail. The head composed of lobules formed by the coiled end of 12 to 14 efferent ductules. The body consists of convoluted duct of epididymis, and the tail is a continuation with the ductus deferens that transports sperms from epididymis to the ejaculatory duct. Now I will give you an idea about a triangle that is presented in the anterior abdominal wall, which is a weakness. If you can say about the anterior abdominal wall, this is a weak part or a weak triangle. This is called the Hasselbeck Triangle or the Trigonum Inguinale. Now this Hasselbeck Triangle is a triangle formed by three structures. So medially it will be the lateral border of the rectus abdominis muscle. Inferiorly, on the floor of it, it will be formed by the medial part of the inguinal ligament with its medial reflected part called the lacunar ligament. On the superolateral side, you will have the inferior epigastric vessels, including arteries and veins. Now through this, you can have what we call the direct inguinal. Now we will talk about the indirect inguinal hernia. Now the indirect is a congenital inguinal hernia. It leaves the abdominal cavity lateral to the inferior epigastric vessels and enters the deep inguinal ring and passes through the inguinal canal. It has a hernial sac with it and formed by the persistent processus vaginalis. It exits the superficial inguinal ring and commonly enters the scrotum. Since most commonly it will go to the scrotum direct. If the entire stalk of the processus vaginalis persists or become patent, the hernia extends into the scrotum superior to the testis. Indirect inguinal hernia can occur in women. However, it's about 20 times more common in males compared to females. There is the direct acquired inguinal hernia. This is the leaving the abdominal cavity medial to the inferior epigastric artery, protruding through an area of weakness in the posterior wall of the inguinal canal. It's called the inguinal triangle or the Hasselbeck Triangle. We mentioned it earlier. Now it is between the inferior epigastric artery superior laterally, rectus abdominis medially, and the inguinal ligament inferiorly. It has a hernial sac formed by the transversus fascia. It does not traverse the entire inguinal canal, usually only its most medial part, or the lower end, adjacent to the superficial inguinal ring. It emerges through or around the conjoint tendon to reach the superficial inguinal ring, gaining an outer covering of the external spermatic fascia inside or parallel to that of the cord itself. Now, which is more common, 70% of the hernias are indirect hernias, and that will leave 25% as a direct one. Now, we will have in this area more one type of hernias, either inguinal hernia or a femoral hernia. Of course, femoral hernia is more common in female, while inguinal hernia is more common in male. Now, from the anatomical point of view, you can find that femoral hernia is lying below and lateral to the pubic tubercle. So this is a pubic tubercle. It is palpable, especially if you are, pressing on the, like in the insertion of the inguinal ligament. So below and lateral. Now, versus the inguinal hernia, which is above and medial to the pubic tubercle. So those are the differences between the two, and you can differentiate it just by allocating the pubic tubercle and then decide where there will be the swelling or the sac will be either above and medial or it is below and lateral.